Okay, so sickle cell anemia, so you're anemic because you drop below those specified numbers that we were talking about, right? So um, in females, there's a certain normal hemoglobin level. In males, there's a certain normal hemoglobin level. What's sickle cell anemia? Well, it's an inherited condition, and it's inherited autosomally recessive. So you need both alleles from your mother and your father. They both have to give you abnormal alleles to have sickle cell disease or sickle cell anemia. And hemoglobin S is produced instead of hemoglobin A. So the globin molecule, because of the genetic defect, is totally different. It's making hemoglobin S. And the red blood cells don't have that lovely biconcave shape all the time. They can alter their shape. They can sickle and become very abnormal. And it typically occurs under some kind of stress. And most often it's a hypoxic stress, meaning low oxygen in the bloodstream, say from a respiratory condition or a pneumonia, and the cells sickle and they can't fit through the capillaries. Okay? And when they can't fit through the capillaries get all blocked. And the organ that was being supplied by those capillaries becomes ischemic. So you can choose the organ and you can then decide on the symptoms. So if the capillaries going to the bones become blocked, these patients get severe bone pain. If the capillaries going to the brain become blocked, they can develop strokes. If the capillaries going to the heart get blocked with these sickled cells, they can get a heart attack. Okay, so it just depends on where the capillaries are being blocked. Okay. Now, what causes what causes the anemia in this case? Well, it's not only the abnormal production of the hemoglobin, but you can imagine all these sickled cells that are going through these, trying to get through these blood vessels. The red blood cells are just breaking up. They're being destroyed because they don't have that lovely shape. Okay? So now there's no cure for this disease. So really the treatment is aimed at preventing from getting sick, right? Preventing what's called a sickle cell crisis, which is where these red blood cells sickle, change shape, and get plugged in different arterial beds around the body, okay? Leading to severe pain, okay? So often these patients need very high doses of opioids to treat their pain. And often, if it's a respiratory condition, they need oxygen. What does oxygen do? Well, it reverses the hypoxia and it allows these sickling cells to try and return to a normal shape. Okay, so I just mentioned sickle cell crisis. So this is someone who has sickle cell disease and they've developed sickle cell crisis typically from a recent illness that's causing hypoxia, okay, such as a respiratory condition. What happens under hypoxic conditions? Well, the red blood cells sickle, and you can see them in the above image there, how abnormally shaped they are. Well, those red blood cells are not going to fit through capillaries properly, and this leads to occlusion and blockage of the capillary beds. And depending on what organ is being fed by those particular capillaries are the symptoms that's going to develop, because they're going to get ischemia to the affected organ, right? And a common example is severe bone pain in sickle cell disease, because the bone can become ischemic and they get severe bone pain. But it can happen to any organ. It can happen to the spleen, and they get severe pain in their left upper quadrant of their abdomen because that's where the spleen lives, right? And basically what's happening is the spleen is not getting oxygen, okay? And so we call this a vaso-occlusive crisis, meaning the blood vessel has become occluded by these sickled cells, and it's a crisis because now there's ischemic pain to that particular organ. Okay, so let's start on the left first. So the effects of sickle cell disease. And it can be divided into the effects of all these red blood cells that are getting stuck in capillaries. So that's effects of vascular occlusion, and we'll go through them. And on the other side, there's the effects of the hemolysis. All these red blood cells are breaking down because they can't fit through the capillaries with the abnormal shapes that they have. Okay? So let's look on the left first. Well, we spoke about a stroke when you have a sickle cell crisis. Why? Because those sickling cells block the arteries to the brain, and it can result in a stroke. And think of it for any of these conditions. So blindness, because those abnormal red blood cells block the capillaries at the back of the eye in the retina. Okay. Acute chest syndrome is where those capillaries got blocked that were feeding the lungs, okay? And they get severe chest pain because of this vascular occlusion occurring in the lungs. The kidneys can be affected because of, again, the blockage of the blood vessels, and you can get renal injury, renal infarcts. You can get renal failure because of all these capillaries that are blocked. The spleen can be infarcted. And actually the spleen in patients with sickle cell disease often becomes non-functional because they've had repeated ischemic blockages to the spleen because of the sickling of the cells. And that makes them very susceptible to infections because essentially they don't have a functioning spleen. Okay. The bone. I mentioned that blood supply to the bone is very important, and when it gets blocked by these vaso-occlusive crises in sickle cell disease, you get severe bone pain, and that makes you prone to infections of the bone, osteomyelitis. Leg ulcers, because it could be the capillaries to the skin, and now the skin's died, and now there's ulcers forming. Okay. They can also get blood vessels blocked to the fingers and the toes, called dactylitis, and the toes turn blue, or they die. They get inflamed and die because of the blockages to the fingers and toes. Okay. What about the effects of hemolysis? So hemolysis is that red blood cells that are constantly breaking down. Well, that makes you anemic. And the poor heart is now having to pump blood much more faster. It has to pump harder, has to pump faster because you're now anemic. Why are you jaundiced? Because you're breaking down so much red blood cells. So you're releasing a lot of heme, and heme turns into bilirubin. So in sickle cell disease, you can become jaundiced. Okay? You have a chronic hemolytic anemia because you're chronically breaking down red blood cells that are trying to fit through all these tiny blood vessels, and they can't do it, so they break down. Okay? You get more gallstones in your gallbladder because you're making so much bilirubin that the gallbladder is filled with higher concentrations of bilirubin, resulting in bilirubin gallstones. Okay? So if you understand the underlying conditions of a part of it is because they're blocking arteries. Those are all the things on the left. And part of it is because of the effects of hemolysis, which results in anemia, and that's on the right. Okay, so I mentioned this briefly, what the focus of treatment is in someone who has um, sickle cell disease and they're coming in because they've become ill, their red blood cells are sickling, and they're starting to not be able to go through capillaries properly, resulting in pain to different parts of their body. Okay, so pain management. These patients, when they have a sickle cell crisis, um, they need extremely high doses of opioids to treat their pain, partly because they're often having to take opioids at home, so they've developed a tolerance. They need oxygen to try and reverse the sickling of the red blood cells, because typically the red blood cells sickle much more when there's low oxygen in the bloodstream. Okay. What about the prevention? Well, so in order to avoid sickle cell crises, well, preventing illnesses, preventing stress and hypoxia that will hopefully prevent the red blood cells from sickling. Okay, so that's also the key. Okay, so let's do two examples of a sickle cell Punnett square. Okay, um, so we've done this in genetics, but let's just have a look here. So the one on the left, okay, um, there's a patient that parent number 2 has sickle cell anemia. They have two small s's, and we'll just say that a small s is an abnormal allele. Parent number 1 at the top has two large s's, and we'll call that normal. Okay, so who has sickle cell disease? Well, none of them do, because you need two abnormal alleles to have the disease. Okay, who's a carrier? All of them are, right? They have one small allele that makes them a carrier. So they have the ability to pass on the trait, okay? But none of them have the disease. Okay, let's look at the second Punnett square. Parent number 1 is a carrier, so one small s. Parent number 2 has the disease, two small s's. Okay, so who is a carrier? Well, there's going to be 50% of the offspring that are carriers. One big S, one small s. Who has the disease in this scenario? Well, 50% of the offspring have sickle cell disease. Okay, because they have a small s, they have two small s's, and that will result in sickle cell disease. Okay, so let's move on to a condition in the bone marrow. Okay, so we're finished with sickle cell disease. Let's move on to aplastic anemia. So this is an abnormality in the bone marrow with the stem cells that are affecting all the cell lines. Okay, so it's going to result in anemia, which will cause all of those symptoms of anemia. And one is mentioned here, fatigue. But there's many symptoms of anemia. The shortness of breath, the pallor, the tachycardia, the weakness, the dizziness, okay? It's going to result in infections because you have a low white blood cell count. And it's going to result in the potential for bleeding and petechiae and bruising on the skin and gastrointestinal bleeding and oral bleeding because of the low platelets, okay? Now, aplastic anemia can be caused by treatments that we give patients, such as chemotherapy agents for cancers or radiation treatments can lead to aplastic anemia. Exposure to certain toxic chemicals can cause aplastic anemia. Okay? There's certain autoimmune disorders that we don't need to get into, but they can also lead to aplastic anemia, which is a reduction of all 3 cell lines in the bone marrow. And lastly, unfortunately, even a viral infection can sometimes trigger aplastic anemia. Okay? So what's the treatment for aplastic anemia? Well, if you're anemic, you might need blood transfusions to maintain your hemoglobin levels. We don't typically give white blood cell transfusions. We try and prevent people from developing infections by giving them advice how to avoid risky situations where they might get an infection, such as crowded spaces, being around sick people. So we give them advice. And lastly, what can be done? Stem cell transplant. So because the stem cells have basically are just not functioning in the bone marrow, if it were to persist, a stem cell transplant could be offered. So a bone marrow transplant to reimplant new stem cells in the hopes that all 3 cell lines will start to develop again. So the platelets, the red blood cells, and the white blood cells. Okay, so this is just showing you a normal bone marrow on the left with normal blood cells within the fat cells there. And on the right, very few blood cells are there because all 3 cell lines have been reduced by a condition called aplastic anemia. Okay, so let's do this question together. A patient returns to the unit from surgery with a blood pressure of 90 on 50, that's low, pulse 132, that's high, and a respiratory rate of 30, okay, that's high. Which action by the nurse should receive priority? Continuing to monitor the vital signs. Well, the vital signs are still are very abnormal. Probably wouldn't be the best option to continue to monitor because they're really not normal and they need addressing. Okay. Contacting the physician, asking the patient how he feels, asking the LPN to continue the post-op care. So definitely see, you could ask them how they feel. Okay. D would be out because you wouldn't just continue post-op care. Something is definitely very wrong here. So contacting a healthcare provider, a doctor, would be the best option here. Okay, this person is hypotensive, tachycardic. Okay, your pulse shouldn't really be above 100. Your respiratory rate really shouldn't be above 18. And normal blood pressure is usually 120 on 80. So these are very concerning vital signs. So the answer would be B. Okay, so let's continue on with iron deficiency anemia. So a lack of iron is leading to reduced production of red blood cells in the bone marrow. And they're going to be small red blood cells, microcytic, and they're going to be hypochromic. So they're going to have less color under the microscope. And when you're thinking of iron deficiency anemia, just think of I'm not getting enough iron into my body, or I'm requiring more iron for red blood cell production, or I'm losing iron through some process. Okay, so let's look at a couple here. So nutritional iron deficiency. So I'm just not getting enough iron in my diet, such as a very poor diet, or sometimes vegetarians or vegans can be iron deficient. Or let's say you're getting enough iron in your diet, but it's not being absorbed from the gastrointestinal tract, such as malabsorption conditions. For example, Crohn's disease, which is an inflammatory condition where the gastrointestinal tract isn't always able to absorb the nutrients within it. Okay. What about excessive iron demands? So I need more iron in my bone marrow. Well, pregnancy has more iron demands because some of the iron is going to the development of the fetus. Okay, children need more iron in their diets, and if they don't get it, they can become iron deficient. And why? Because children are growing and they require the iron for continued red blood cell production, more and more of it. Okay? And finally, chronic blood loss. So you're losing blood from somewhere. And by far the most common place is either the gastrointestinal tract, which is just gradually losing blood, such as in a peptic ulcer in your stomach or your duodenum. Say you have esophagitis, which is just dripping a bit of blood constantly. Okay, you're losing iron that way. Gastritis is just inflammation of the stomach, and that can cause some iron loss, some blood loss. Colon cancer. If you have colon cancer, it can bleed slowly, and it can result in iron deficiency. Okay, so anywhere in the gastrointestinal tract where you're slowly losing blood, use of anti-inflammatories or blood thinners can aggravate any of the conditions that I just mentioned, right? So non-steroidal anti-inflammatories cause inflammation of the stomach. They can lead to a bleeding ulcer. And finally, blood thinners, such as warfarin, or other blood thinners that we use that make bleeding more significant. Okay, so say you had something that was bleeding a little bit, well, now you're on a blood thinner, it's going to bleed more, and you're going to lose red blood cells, and in the process, you're going to lose iron. Monthly periods, so menstruation. Women that have heavy periods are losing more red blood cells and losing more iron. So in order to keep up with that, they would have to consume more iron in their diet or through iron supplements. Okay, so just categorize it. How much iron is coming into the system? How much iron does my bone marrow need? And am I losing any iron from anywhere in the body? Okay, not too much time on this slide since it's really saying the same thing. So top right, nutritional deficiency in your diet. Just spoke about that. So meats tend to be very high in iron. Vegetarians or vegans can be iron deficient, okay? Or someone who just has a very poor diet and just doesn't get iron in their diet, okay? Bottom right, faulty or incomplete absorption from some kind of gastrointestinal disease that causes or leads to malabsorption. Increased physiological demand, well, that's going to be pregnancy. That could be a child that just needs more iron to maintain its hemoglobin. Excessive loss. So excessive loss could be typically the gastrointestinal tract or heavy periods or any kind of ongoing slow bleeding. Okay, so for example, if someone comes in with iron deficiency anemia, we're going to look very hard at the gastrointestinal tract. We often send these people for scopes. So a gastroscope to look in their stomach and a colonoscopy to look at their bowel to see if they're losing blood from any of those sites, right? So excessive loss on a chronic basis will lead to iron deficiency. Okay, so continuing on with iron deficiency anemia. So the first statement here is referring to any anemia, low hemoglobin and low hematocrit in the blood. Okay, when we're talking about iron deficiency, it's due to the lack of proper iron supply. Okay, what's ferritin? Well, ferritin is a protein that stores iron, typically in the liver for the most part. So it's a very useful blood test that we can do to see if the ferritin levels are normal in the bloodstream. And if ferritin levels are normal, that's telling us that the iron storage within the body is normal as well. So if the ferritin level is low, it's a very strong indicator that the iron stores are low. Okay? So instead of just checking an iron level in the blood, which is just telling us, okay, what's the iron in the blood on that particular blood test, the ferritin level will tell us what are the iron stores in the body. Okay? Transferrin is just a protein that carries iron through the bloodstream to different tissues, including the bone marrow. And we don't really use it as a test of iron storage like we do with ferritin. Okay, so what's the impact of iron deficiency on the red blood cell? Microcytic hypochromic red blood cells, tiny cells that have reduced coloring when we look at them under the microscope. Okay, so you can see that when we do a blood test such as a CBC, we look at the MCV and we see if it's showing a small red blood cell, because that immediately will help us determine that, oh, this is a small red blood cell. What's the most common cause of small red blood cells? Iron deficiency anemia. Okay, there's other causes as well, but by far the most common is iron deficiency anemia. That's causing small red blood cells. In fact, iron deficiency anemia is the most common anemia out there, okay? Because lack of iron in our diets or some kind of process that's causing us to lose iron, such as heavy periods, or losing some iron in the gastrointestinal tract, is relatively common. Okay, so this slide will help bring the concepts that we've just been talking about together, right? So the 4 different sections that can lead to iron deficiency anemia. So top right, poor intake. To the right still, poor absorption once it gets to the gastrointestinal tract, such as a gastric bypass surgery, or any condition that leads to malabsorption, such as celiac disease, which is an autoimmune disease of the gastrointestinal tract that can affect the microvilli of the small bowel and lead to poor absorption. Crohn's disease, I mentioned, that can lead to malabsorption as well. We'll talk about it in another module. Okay. So what about PPI and antacids? Well, chronic use of antacids reduces the acid in your stomach. And the acid in your stomach helps with absorption of iron. Okay, so if your stomach is constantly having a higher pH, you're not going to absorb iron as well. High caffeine consumption. Caffeine is a stomach irritant. It can lead to gastritis. Okay. What about blood loss? We've spoken about. It's typically either from heavy periods or peptic ulcer disease, it's bleeding, gastrointestinal malignancies, inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis. Well, they cause bleeding, right? So during the inflammation, they're also losing a bit of blood. So that can lead to iron deficiency. And then the physiological states that require more iron, pregnancy and childhood. Okay, and this slide's just showing you what microcytic hypochromic cells look like from iron deficiency. Okay, so they really are lacking the color of red blood cells, and they're typically smaller overall than regular red blood cells. Okay, so here's some interesting changes that can occur with chronic iron deficiency anemia. So spoon-shaped nails, where there's an indentation of the nails, making them look like small spoons. Pica is a craving for a specific type of food, or even not even a food. So patients can crave non-food items as well. Okay. Glossitis is swelling and inflammation of the tongue. That can occur with iron deficiency. And finally, stomatitis. You can get inflammation in the mouth, and as well, you can see in the corners of the lips here, they get skin breakdown, fissuring, and inflammation as well. Okay, so these can all be symptoms of chronic iron deficiency anemia. Okay, so let's move away from iron deficiency anemia and let's talk about some vitamin deficiencies. Okay, so and in particular for red blood cell production, we need vitamin B12 and folate. Okay, so what can cause a vitamin B12 deficiency? Well, you can have a very poor diet of vitamin B12. That's relatively uncommon. Okay, because you don't need large amounts of B12 to maintain a proper level in your bloodstream. Okay, what about malabsorption? You can definitely have malabsorption because vitamin B12 is dependent on a factor that's produced in the stomach called intrinsic factor. And if your stomach is not producing intrinsic factor, such as with the aging process, that can definitely happen. You get a condition called atrophic gastritis. Atrophic means your stomach just isn't functioning the way it used to, and it's starting to atrophy. And you don't produce normal amounts of intrinsic factor. Okay, so that can lead to malabsorption because B12 needs to attach to intrinsic factor to then be absorbed in the distal small intestine called the ileum. Okay. What about inflammatory bowel diseases such as Crohn's disease? Well, Crohn's disease happens to affect the ileum, so the distal part of the small intestine. So if you have a disease that's affecting the area where the B12 and the intrinsic factor wants to get absorbed, well, you're going to have malabsorption of B12 because there's a diseased area of the bowel. Okay. What about surgery? Well, if you have your stomach removed, then you're not going to have any intrinsic factor to take the B12 and process it through the gastrointestinal tract and get it absorbed in the ileum, which is the distal small intestine. Okay. What about folate deficiency? Well, this is much more easily done to become deficient in folate. So just a poor dietary intake. So an older person, an alcoholic that has a very poor intake of folate, and many other vitamins and minerals. Okay. What about increased demand? So pregnancy, you could have increased demand for folate, and that's partly why women take folate in pregnancy, not only to minimize the chances of a neural tube defect, but they also need it for red blood cell production. Okay, malabsorption in the gastrointestinal tract can affect any vitamin, so that's why it's added there. And there's some drugs that we use that can cause folic acid or folate to be ineffective. Okay, but that's not a big reason. So the main reasons for folate will be dietary deficiency of folate, such as in elderly and alcoholics, and potentially pregnancy. But typically women that are pregnant are taking folic acid. And of course malabsorption. Okay, so when we're talking about a vitamin B12 or folate deficiency, that's going to result in very large red blood cells, so megaloblastic anemias. Okay, so when we look under the microscope, large red blood cells appear. Okay, and also there's anemia because there's just not enough of them being produced as well. So what does B12 or vitamin B12 and folate deficiency do? Well, it reduces um, uh, the maturation process of the red blood cells. So it's required for DNA synthesis in red blood cells, and because of the lack of vitamin B12 or folate, there's decreased cellular division, right, resulting in large red blood cells. They're not dividing, and decreased nuclear maturation. So think of B12 and folate deficiencies as causing the red blood cells not being able to divide properly, so they're staying as large cells, megaloblastic cells. Okay, so that's going to cause an anemia. Okay, so it's going to cause a low hemoglobin or a low hematocrit, just like any anemia can. But when we look under the on a blood smear under a microscope, we see, oh, those are large red blood cells. So it helps us determine, okay, so they're large red blood cells and the patient's anemic. I need to think of vitamin deficiencies such as B12 and folate. And by the way, alcohol can cause that as well.